Welcome to the Women's Health Podcast. I'm Marika Hart from Herasphere.
And I'm Anthony Lowe, the Physio Detective. Together we interview leading authorities, answer questions, and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember the materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now it's time to get cracking with the episode, so whether you're out walking your dog, driving the kids to school, or just sitting back enjoying a glass of wine, we hope you enjoy the show. Hello everyone, welcome to the Women's Health Podcast. Marika Hart here, and as always, my buddy Anthony Lowe sitting over in Sydney. How are you, Anthony?
Doing well, thanks, Marika. How are you?
Not too bad, thanks. I'm assuming you're insanely busy as always.
Yeah, I just finished teaching a course. It's the last of my weekend commitments, so I might get a weekend off. Well, not this coming weekend, but it'll be the first one for the year, so that'll be nice.
I don't even know how you do it. I've just come off 80 kilometres of hiking up the Bibbulmun track without children. Came back just so calm and peaceful, and it was blissful. I'm very grateful for that opportunity, to be honest, because I feel like it's been a tough couple of years, hasn't it?
It has been.
Yeah.
Definitely.
And we have a special guest today called Kieran Richardson. I'm very fortunate to work in Perth with Kieran. He's a physiotherapist. We actually were on a musculoskeletal committee for a short period of time together, and we just discovered that we both kind of probably weren't the best committee members, were we, Kieran?
Look, I wouldn't say I was a bad committee member. When I was there, I felt like I was contributing, but then I changed email, and then I think they kept emailing my old one, which I just disengaged from, and so I just slowly exited stage left. Like just slowly left, and then just haven't gone back.
Fell off the radar. I'm sure they're missing your expertise. I'm just going to introduce you to people who don't know you. He's actually a specialist physiotherapist, and for those that don't live in Australia, we kind of have a hierarchical system of training, and to get to a specialist level. Oh, you can tell us about that process later, Kieran, but it's pretty full on. You already have to have had a lot of postgraduate training and experience, and then you go through another couple of years, and there's a lot of examinations and a lot of peer reviews and things like that. So to get this level is really quite something. And he's a director of a business called Global Specialist Physiotherapy, and it's a consultancy company. And what they do is a lot of PD for physio clinics, mentoring, and do a lot of non-surgical opinions for patients. And in particular, Kieran's very passionate about ACLs, and we'll talk about that later. So Kieran and his team of academics and expert clinicians and researchers, they do lots of consultations to lots of different physio clinics around Perth and WA. And I do believe you've got someone in Melbourne now, haven't you?
Yes, yeah. I guess since the coronavirus pandemic, we've been having a lot more clinics engage us live via Zoom. And I don't know do people still use Skype, but it's mainly been Zoom. And yeah, so I just have been looking for another consultant for a while, and some ones in Perth just weren't available. And I just figured, well, why not reach out to some people in Melbourne? And yeah, we're very fortunate to have Karina join us, who's a postgraduate physio in sports. And yeah, it's pretty cool.
Yeah, and on top of that, he's running lots of courses, doing courses on the non-surgical management of ACL tears, and this new one on manual therapy. Is it, Kieran?
We called it the Manual to Great Therapy, which I thought, being a dad of 3 girls, I'm allowed to do dad jokes willy-nilly. So I thought that was quite a good dad joke / witty. And yeah, we won't maybe get into too much detail on that. We can later, but if you want, it's up to you guys. We can go deep dive straight into that now if you want. But yeah, I just think the whole manual therapy thing is, I guess, a conversation that if you look on social media, can be a lot of outrage, spot fires left, right, and center. And to me, I don't really understand why that is. And so myself and James Schomburg, who's an academic clinician, from South Australia just decided to start a 2-day course where we review the research literature, when we should use hands-on, when we shouldn't, and why it can still be cool. It doesn't have to completely be put on the shelf.
You're taking some of the controversy out of it, aren't you?
I think well, that was the plan, because we don't really see why it has to be so divisive, really.
100% agree. Look, why don't we sort of take a little bit of a step back then, Kieran, and talk about your, how you got started in physiotherapy and why you wanted to be a physio. What do you love about it?
Yeah, so like in high school, I actually was contemplating physiotherapy, medicine, and then I considered teaching, and then also accounting. And it only took doing one day at an accountant to realize that wasn't something I wanted to do. I actually quit like after a day of work experience. I was like, I can't do this. Like, it's just too boring. They actually call most accountancy sections in businesses the morgue. I don't know if you guys have heard that. But yeah,
where people go to die.
Pretty much. And it's just lifeless. No, I love accountants though. But then, yeah, I went into a Bachelor of Science because I didn't get, back then, physio was actually higher than med to get in. So my score wasn't good enough to get into physio. So I did a year of a Bachelor of Science and then did pretty well, transferred into physio, and then did undergraduate physio. And even at the end of physio, I wasn't really sure if it was something I wanted to do as a career. And so I was looking into going into medicine and even law. And then I just worked in a hospital and kind of gained my footing there, and worked in a few different areas and rotations, and had a special interest in orthopedics and musculoskeletal. Working in outpatients really started to cut my teeth. Then moved into private practice. And early on in my career, I was supervising students, and I guess I had the clinical doors open more. And so, I guess upskilling in the clinical nuances of physio seemed to be opening up to me. And then started working in private practice, and then was able to do my master's at Curtin, which is a fantastic program. Some real heavy hitters in research and clinical world there. And as you're saying earlier, was able to then go on and do my specialist training, which was I actually found, I probably shouldn't say this, but I actually found the masters harder because I found so much reading, whereas the specialist was more self-directed. You could sort of choose your own path, and you just had to have people validate it. So I found the reading part of the masters really hard, because it'd be like 10 articles a week or whatever. So I found that particularly difficult. But yeah, and I've just since then been involved in mentoring and have been fortunate to have people that work with me that are great mentors, and I just value that as a part of the profession. And I really think that availing yourself to other people's opinion who may be more experienced or having a different view to you isn't necessarily a bad thing. I think that if you can do that consistently, not just in, I guess in all elements of life, but in physio, it's just been, personally, it's been very helpful for me to have other people question my views and challenge my thinking. And so, yeah, that's, I guess, the path that I've taken to this point.
Nice. It's an interesting thing, isn't it? How people get to where they are, and it looks like, you were trying many different things, and ended up in physio, making it through all the different training that you've done. With respect to, the mentoring side, supporting people's side, but also just how your career maybe has been influenced by things like, well, if you did the science degree and then you did the master's degree and then you did the specialization training, how did the research, the evidence-based practice, and what that might have looked like over the period of time, how did that look? And we can talk about ACL. You have a passion for ACL, manual therapy. and how that relates to how you might assess and manage some of the things that you see, you know?
Yeah, I guess my undergraduate degree was completed in the early to mid 2000s. So everything was very technical back then, very specific techniques and related to almost that whole body as a machine. You would do a biomechanical test and you would do a biomechanical treatment. I didn't really excel so much in undergraduate. In fact, I found a lot of it quite confusing. And then when I would go and try this stuff on patients, I would really be faking it till I make it, and it just didn't really add up to me. And then when I went and did the masters, I started to realize, this whole biopsychosocial was coming out around then, 10, 12 years ago. And I started to see that, okay, I didn't actually have to hold so strong to some of those more technical aspects of physio. And then even still going into the specialist training where it was very heavily evidence-bound, arguably too strongly. And you start to realize that there's a lot of research evidence out there, and most of it's poor quality, which is difficult for some healthcare practitioners to sit in and to sit in that grayness, and it's not to say that everything's gray in health, but it's far more gray than people would like to admit. And so I've just, I guess, with my reasoning I still have evidence as a default. I love that, and I'll always love that. And I think it's, as scientists, we have to have that. But I think how we interpret, a patient in front of us based on the research is far more individualized, far more heterogeneous than we used to think 20 years ago, where it was very one size fits all. And so that's I think it's quite relieving, to be honest, as a clinician, because you're pretty open to seeing quick changes. And if you're not, then you're more happy to refer on or get different opinions. I guess that would be, I don't know if that makes any sense, but that would be how I've sort of shifted in my views and practice, and I guess grown.
Sorry, did you have a follow-up question, Anthony? You're good. I just was wondering, Kieran, in your experience in mentoring, do you find then there's a lot of confusion about evidence-based practice as being it is all about what the research shows and it's only RCTs versus, that true description of evidence-based practice, which is, those different elements and its experience and it's all those other things as well. It's not purely research.
Yeah, I think with mentoring, I love it. It's one of the favorite parts of my working week. Honestly, it's so enjoyable. And then seeing someone shift and change and then get superior outcomes is just, it's lovely. It's tough though, because each physio has to be, or it's not even physios that we do mentor outside of physio, but they have to be open to someone challenging their thinking and reasoning. And it is quite vulnerable. You have to be quite vulnerable. And some people are quite defensive on that, initially, not all, but I've seen a bit of that in my time. And to be honest, I think I was like that when I first started. I was a bit resistant and it's all, you get all manner of interpretation of how a patient is now. So some of the more new and recent graduates can be very heavily, empirically evidence bound. And so they're wanting, they might read a systematic review or meta-analysis that says, there's very poor quality of evidence to do X treatment. And so they will write that off. But then the patient might still want that. And it's not to say it's wrong. And so we'll see that. And then you see, on the other spectrum, you'll have some people that are very strong in their view based on their experience. And it's, you can't necessarily dramatically change that straight away. And in fact, as a mentor, trying to change people that have a very strong view, you can almost get, if you try to change it too quickly, you get that reaction where they get even more aggressive. And that you see that online in different conversations. And I guess even now with social media, like the social media thing has just polarized a lot of these topics even more. And I like to put stuff out there online, and you can present the most balanced, evidence-based view, and people will still just kick off. And so you've got to be comfortable as well that you can't ever make everyone happy. So, but the mentoring is great, and I wish more physios would and healthcare practitioners, not just physios, but healthcare practitioners would avail themselves to people giving them not even contrary, but just alternate view. Yeah.
Totally agree with you, Kieran. Marika's laughing because she knows what goes on in
he does a lot of mentoring, and he has all these analogies about trying to shift the Titanic, and
yeah.
Yes.
Well, I was going to say lots of people like to try and change the course of a cruise liner by running into it with a tugboat, instead of getting alongside and doing what a tugboat does best, which is gradually make change. But in a lot of the stuff that I do, I actually tell people now when they do, it's called the masterclass, that you're going to probably have an existential crisis. I developed a course that goes through the first 5 weeks of a 12-week program that you can do with me. It's super cheap. It's $100 US. It'll take you through that with reflection questions and everything to try and lessen the impact of that existential crisis. And people still have the existential crisis even after having done that. It's full on, man. I agree with you.
Yeah. And so I think I probably, as a mentor now, am far more gracious, because I'm so desperate often to just see the changes, because I've seen it work in myself and had dramatic shifts in thinking. And so I want to help people with that. But I find that some people aren't prepared for that. They're not prepared for that level of reasoning. They're not prepared for that. It's almost Matrix-esque, Are you going to take this pill? If you take this red pill, do you know where we're going? So I said that to a mentee the other day, and he was ready to take the pill. And we went there, but not everyone's ready for that. And it's just, especially if you've been experienced and trained, not everyone's ready for those very deep level conversations straight off the bat. I try to gauge whether they're ready or not, because I like going there straight away, but it doesn't always. It can get the reverse effect. Yeah,
the backfire effect is for real. So with respect to, you just it's hard in the middle, isn't it? Because you're never going to please everybody. You're not extreme to one side or the other in whichever direction you choose to go. That's why everybody doesn't like us who sit in the middle. In terms of going where the evidence is, you mentioned incorporating what people want, navigating the complexities of garbage in, garbage out when you do a systematic reviewing them. How's that balance, and how do you see that work out in terms of walking the line, doing manual therapy, dry needling, traction, electrotherapy? Like, all of these things don't have evidence that they're superior to anything else, but they also often are better than placebo. So, how do you navigate that on a day-to-day basis?
Yeah. So, I mean, I would say that, sometimes, like, for example, with ACL, the culture and rhetoric is very, very, very extreme towards surgical. It could not be more extreme, really, even now. And so sometimes you, even by taking a slightly off-center view, it would be considered very out there. So I think there are some things where you can sit in the middle, and I think it's good. And I think other times, even by sitting in the middle or slightly off middle, it's considered extreme, because the current view is very extreme. And I think physio is guilty of that in various areas. I do like the Sackett's model. Sackett's from the mid-90s, where you have what does the best, the kind of three circle intersecting Venn diagram, where you have most empirical. What does the patient want? What do we think? And do we sit somewhere in the middle? And can we try and find a middle ground? I think that's a pretty good model. And you get the people that are hardline empirical. And I love the empirical, so much so, as I said, that I almost considered doing law, because I was so frustrated with the lack of evidence for treatments that were being applied on patients. But I think you always have to consider that individual. And in physio, it's hard because most of my real passion is cultural trend outside of physio. Not so much, like, I love the profession, but I see what we can add extra professionally, to within healthcare, which, this might sound controversial, but healthcare is dominated by medical, completely dominated. And so physios have these arguments about various issues, but in the grand scheme of things, we're struggling to make a dent because we can't even agree on pretty simple stuff. But as a united force, I think we can. But most of the real world issues and the harms that we would cause are insignificant compared to some of the other massive meta issues that are going on in health. So that's probably where my big passion is. And so it can be frustrating seeing some of these, what I see as spot fires, non-issues, where if we could all agree, at least in part, we could have a greater influence, probably not just even physio, but allied health as a corporate. Because the reality is the majority of the claims are of item numbers and claims that are processed in health are medical. It's not physio or allied health even. So yeah, that's where my real passion is. But shifting that juggernaut is huge.
Yeah, take that on board, buddy. That's it's that gives a lot of food for thought, really. And I mean, I know, just going to the social media side, we had a very quick conversation off air, and we talked a little bit about how within the physiotherapy world, for those that aren't physios, there has been a little bit of back and forth over the last few years about whether or not actually putting our hands on and doing massage and manual therapy is a total waste of time, whether it's all placebo, whether it's making people more dependent on physios and not making them independent. And so there's, it's like this pendulum bloody swing where we've gone from being so biomechanical, like Kieran was saying, very picky about, this is an upslip, downslip, we have to mobilize this number of times, put this back into place, etc. And then we've gone, hang on, that wasn't right. So we chuck everything out and we do not touch our patients, and we go, everything is about pain education and getting people strong and just getting people in the gym. And it's funny because Auntie and I very much sit in this middle space where we put hands on people all the time. And I'm thinking about, a patient I saw a couple of days ago who's got, acute pelvic girdle pain, who's pregnant. Now, I know the evidence for manual therapy is not great, but I can tell you in that moment when she got up and went, oh, thank God, I feel so much better, thank you. I think, well, would I deny her doing hands-on because it, in quote, doesn't work, it doesn't make a difference? And so we've then got this, situation where online, if someone says, oh, you do some manual therapy on this, you've got someone else going, well, that's bullshit, that doesn't work, we know in the evidence. And then, and like you say, it's, to me, half of it's such a bloody waste of time, because it's not actually, the arguments are not furthering the profession anymore. We're not actually making any kind of useful movement to help our patients. Whereas, as you said, there are probably bigger things that we could be focusing on. Yeah, that was a bit of a tangent, sorry.
No, yeah, I mean, be good to get Anthony's opinion and his what his take's been as well. But I mean, yeah, I was saying off air, but I've probably been almost unwittingly dragged into this conversation. Like, it was just sort of been this massive non-issue for me. I don't see why. First of all, social media isn't the barometer for controversy. That's the first point I want to make. Because there's a lot of stuff they'll go, oh, outrage, in the news, they'll say, oh, outrage, as someone said this. And it's like, what? Who cares? Like, so, but in terms of at least at a systematic review level, there is research evidence for pelvic girdle pain treatments, taping, basic manipulation, massage. Is it great evidence? No, but it's still something. There's still some evidence for it as a package of care. And I think, and if you look across the body, you don't have to dig too deep into the research evidence to find at least systematic review level. Is there meta-analysis level in some areas of the body? Yes, for manual therapy exclusively. But none of us would just have a patient walk in, we say nothing to them, you do a MOB, they just walk out. Like, that's not how it happens. And so I think I really feel for the patients, as you said with that one the other day. I feel for the patients because I've lost count now how many patients have come to me and they'll say something to the effect of, I wish the physio would just put their hands on me. How can they know what's wrong? They didn't touch me. And it's a bad look, because if they don't, especially if I go back to my big bugbear, if they don't get even if it's palpating. I had one physio try to argue with me it was contraindicated to palpate a patient. And that was one of the cases, Anthony, where I said, look, that's false. Like, you can't say that. That's not true.
What would be contraindicated? How?
This person had acute low back pain. And she said, she said, and genuinely, she wasn't even being particularly defensive. She just said, I honestly thought it was contraindicated to palpate a patient with low back pain. So I think that is how extreme, even though I don't think that's been the intent of some of the conversation, that's what some new and recent graduate physios have picked up. And so, I've had that on multiple occasions now, and I do second opinions every day. And I've had patients say that, and then they may have a true movement impairment, probably where the hands-on is going to be more indicated. But even if they don't, there should still be some assessment of the patient from a palpatory point of view. Anyway, but so I just find that with conversations like manual therapy, it leaves the people that want to use it case by case feeling almost guilty, which isn't supported empirically. But then, they feel disillusioned, and then they have the patients telling them they want it. And so I think they need to know it's not wrong to do it for a bit. It's not. There's nothing. I can't find any compelling evidence to suggest that. There's actually a really good article by Professor Roger Carey, and he came out and said the title of the article is something to the effect of "Hands on, hands off. Is that even a thing?" And he basically goes through all the best evidence and says, we cannot say manual therapy does nothing. We cannot say it makes patients passive dependent. And we can't say that physios over service. And he does it in quite a brilliant, and he has a little bit of satire in there as well. But yeah, I just feel for the patients mainly, because I've had quite a few say, oh, the physio said it was in my brain. Pain was in my brain. And I'm like, they're very straightforward cases. They're not even particularly complex cases. They're certainly not chronic, widespread, persistent pain, functional central sensitization state, or whatever you want to call it now. But
yeah, it's a difficult thing, isn't it? Where the sound bites, and believe me, I am a soundbitey type person. Like, I like my pithy sayings because people remember them. But it's difficult if we get a situation where you're the best physio in the world and I've got no patients here because nobody wants to come see me. I just tell people it's in their head. They just go see somebody else. I agree so much with what you're saying. This is certainly not the podcast I imagined that I'd be sitting in listening to today. So fantastic. Love it. I get in trouble. This is what I get in trouble for on social media, Kieran. I get in trouble for saying maybe we should use a biopsychosocial approach in our discussions with our colleagues. And that's what I get slammed for. No, they're professionals. It's on them to keep up with the research. It's like, I agree. We can still use a biopsychosocial approach, meaning recognize the person, understand their background, where they came from, their education, what's at stake for them, where their mind is at, where their psychology is at, what's at stake for them, and the theories that they hold on to, and get alongside people. Oh, no, 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 Anthony, that's terrible. How dare you suggest something like that? That's what I get in trouble for suggesting that we actually treat other professionals as human beings. Pretty sad state of affairs, I think.
Yeah, yeah. And I think for patients, they're none the wiser with this stuff. So, I enjoy having these thought experiments with other physios, and even other medical disciplines and allied health. I do enjoy, I really enjoy that. But this stuff is very high above where the patients are at, with all due respect to, even the patients that are not medical or health at all will still not be at that level. Their thinking and reasoning and understanding of what we're trying to explain to them this is empirical now, would say it's far less, significantly less. Most of them understand at a year 5 level, at primary school age level of understanding. And that's not being disrespectful to the general population. That's what the health literature would say. And so physios will want to have these conversations, which are great. But at the end of the day, a lot of the stuff is just misunderstood by patients, because as you're saying, the physios are trying to communicate to the patient as if they're a physio, but they should just be, like you're saying, talking to physios like that, but talking to patients differently. I feel like we should talk to patients one way, physios one way, medical or extra professionally another way. But even that's quite triggering for some people.
I would say that we should speak to them the same way, and that is meet the person where they're at and converse at that point. In that way, it's the same. But what that looks like, I agree with you, it would look different. And when I've got a doctor here seeing me for treatment, I still speak to them like a person, because personally, I think experiencing pain, experiencing injuries, experiencing symptoms is very different to being a therapist helping somebody experiencing pain, experiencing symptoms, experiencing injuries. And the most common comment that I get from healthcare providers, doctors, physios, everyone else is, thank you for not assuming that I should know what to do, because I don't. It's really hard to assess yourself, In terms of the application of the research, this is called the Women's Health Podcast. I'd like to talk about women's health side of things. In terms of the application of, say, the ACL research in female athletes, we could look at, persistent pain in clients, pelvic girdle pain in pregnancy. How do you see where we've come from, where we are now, and where we will be in the future, hopefully based on the evidence, based on the conversations, based on the cultural climate that we've got?
Yeah, I mean, I wish we could talk probably for the next 5 or 6 hours about that, as a standalone point or a standalone question. Depends where we want to go. With, as you know, and as you guys know, like, we have research evidence and its translation is very slow. And that's probably the thing that existentially I'm struggling with, is I wish it was quicker. I wish policy, there could be 1 or 2 policy changes rubber stamped quickly that would completely change the game. But it just doesn't. There's lots of other mitigating factors that are non-evidence based. Resistance from different groups, including political, which I had never even considered before I started looking into, this, at least the ACL topic. Why is there such resistance to high quality evidence when it's being produced? For those who can't see, Marika's just doing like a money gesture.
Well, can we just say you probably put a few noses out of joint, because got to pay for some private school fees and cars and things through surgical interventions. I didn't say that.
Well, look, I do think it would be a particularly jaundiced view to homogenize that, to say that it's, there's private elective surgeries are, a for-profit system. if you don't want it to hear it from a physio, you can hear it from an orthopedic surgeon. So you could listen to the New World podcast and hear Ian Harris talk on the topic. I think on the whole, all healthcare professionals want to help patients. They do. I think they do. I really do. Maybe I'm wrong on that. But unfortunately, in the Australian system, it's very commission style. And that is a significant driver that is spoken about by some researchers. Ray Moynihan is a fantastic researcher who used to be a journalist, and he talks about that pervasive effect of and the sort of almost seedy influence of business and healthcare, where it can be you're treading an ethical fine line all the time. And so I think probably 5-6 years ago, I was more naive to that. I didn't appreciate it as a factor. Is it the dominant factor? Very hard to know. It certainly, people wouldn't be explicit about it. It'd be difficult to get people to, go on the record and talk about that. But, for ACL, without question, the current rates are not justified. Like, they're not justified by the research evidence. And I think part of that is also that the policies and the systems that were created 50 years ago, where the model of thinking was different. And so to try and get that updated is very hard. It's a mega system, very powerful system. And then some people want to keep that perpetuated. And so not all, though. Heaps of people. There's
also in part patient beliefs, isn't it, though, Kieran? Because, when we were chatting to Adam and Andrew about this before, but, we've all sort of come through a system where if you're athletic and you play a sport that changes directions, you have this surgery. So most people in the community have an understanding, and I could talk to my husband and he had his done 10 years ago. That is the understanding. And if you play sport, you get it done. And so I guess from a consumer perspective too, it's the consumers are thinking, well, this is still the best thing to have. This is the gold standard.
Yeah. And so
how do we change that?
That's a great question. So I could sort of give you a broad overview, but Josh Zadro and Evangelos Pappas, who was at University of Sydney, is now at the University of Wollongong. He's a professor. Josh Zadro, who are doing a little bit of research on for the quality of evidence on ACL websites in around the world, is very poor. It's very hard to try and find high quality information for patients. But in their editorial, they wrote this editorial recent, I think it was like 2 years ago, which we could put in the show notes. But basically, there is this almost expectation from patients that surgery is a quick fix, quote unquote. And so they don't know that they commit a type 2 error because they don't know there's another option. And so, if you were to try and sum up my view, it would be, in a majority of cases, patients should be encouraged to wait, like anything elective. And you kind of go through stepwise the process as to whether you ultimately need that, whether it's, total hip, total knee, knee arthroscopy, ankle reconstruction, ACL reconstruction. It should be that pathway, but with the model is flipped, where the patients get access to that stuff early. And, it is harder. You have to get the patient engaging in exercise. You've got to get them shifting their thinking. You've got to get them emotionally calm. If it's elite level, which I've had quite a bit of engagement with, the system is driven, is significantly different to general pop. Like, general pop's fairly straightforward. Elite level's a whole nother beast. The athletes aren't really in charge of their own destiny. They may be a bit, but it's mainly a lot of the there's contract pressures and the club pressure, media pressures. So this is a significant amount of factors that all move very fast.
It definitely comes at a cost, doesn't it, for them? And So what I was hearing you say is that too many female athletes are doing their ACLs. We've talked in the last podcast about the contributing factors, injury prevention, but also the delay in getting that surgical or the surgery. Really, I don't know. Around here, it's not too bad with the people that I see. It's okay to be told to wait here, it seems, but maybe they're just really busy. But
Well,
I like to think it's evidence based.
Same. And I think prior to COVID, Australia has the highest rates of reconstruction in the world per capita. Don't do a fist bump. But yeah, so
that was a sarcastic winning there.
Oh yeah. So we're winning. Woo. But yeah, I think probably now patients seem like that's definitely been stymied because of the pandemic, for sure. Like literally elective surgeries were cancelled. So that's in some sense is good for patients to start contemplating, considering their options more. For the female athlete, I haven't listened to the last episode, but I'm sure they would say that females are significantly more likely to injure their ACL. But based on the best evidence, the outcomes are pretty similar for male and female, whichever path you choose, surgery or not, which is encouraging. In fact, there's another controlled trial that showed very similar just recently, that at least 50% of people don't need the surgery. And the ones that choose the surgery don't seem to have significantly clinical better outcomes than the ones that don't. So that's the dilemma. But all of the funding is towards surgery, without question. So I think there's physio couldn't have a harder, like physio or people advocating for multiple options at least have got a very tough battle. You were going to say, Marika?
Yeah, I was, and I just lost my train of thought. Damn it, what were we going to say? Oh yeah, sorry. In terms of clinical pathways, like in some conditions, we'll have clinical pathways that are evidence-based and that are put together by the big representative bodies. Are there actually clinical pathways for ACL injuries that actually have a recommendation to do, have this scan, try a period of, we don't call it conservative rehab, do we, Anthony? We call it sexy, cutting edge, aggressive.
Sexy, cutting edge, progressive.
Progressive, no, not really.
Not rehab.
No.
Management.
This is a conversation.
High quality scientific exercise.
Leading edge stuff.
Cutting edge, yeah.
I actually, although you guys, I know you're joking, but that's what
we're not joking.
That's how.
No, we're not joking.
Well, yeah, I'm serious. I think it's good. That's exactly what I say, and I think patients, when they have it presented to them like that, in my experience, I just saw one earlier, like a non-surgical ACL, just a patient just an hour and a half ago, and he's I said to him, I've done hundreds of these. I've not had a patient regret waiting, not one. And even the ones that have ultimately needed the surgery or had persistent episodes of instability who probably fit the criteria for surgery, not had one regret waiting. And so the pathways on the whole are basically, if you look at Medicare, they can get a free MRI, they can get a free GP consult as a part of that. They can get a free surgeon consult and free surgery funded, but you don't get physio funded in any of that. So that's the challenge. There are some primary care setups in Queensland where the physios actually triage to the surgeon. So my big view and hope is that in the next 10 years, we could see not just in ACL, but across all musc, you have these centers, hope potentially including in private, and even in GP centers, where you have an experienced and trained clinician who triages MSK. And then the patients that truly need surgery, and you're flagging that early, or they've got potential red flags, or they need imaging, they need pharmacology, they need injectables. They can streamline that early. And the UK models and in Scandinavia, they've shown that this is highly cost effective, very easy to roll out. But you do need policymakers to rubber stamp that. and it's harder than we'd like to think. But that's how I see physio moving into that space, and we can be very effective. I don't know what you guys think about that, but
yeah, I think having physios in charge, can't remember his name. Jeff, someone at the Dockers, was in charge of
Jeff Boyle.
Boyle, that's it. Don't mention the Dockers. Look at that smile that Marika's got on her face as soon as you mention the Dockers. My goodness.
I'm a Dockers fan as well. And
my goodness.
We're rebuilding. And
I was going to say, aren't you always rebuilding?
They're depressing, actually, to be honest, supporting them. I don't know why I still support. Yeah. I wish I came from New Zealand. I came from New Zealand in 1995, the same year the Dockers started.
Another one.
And so, so I'm also a Kiwi.
How did you all end up in Perth?
We're taking over. So, but because the Eagles had won the year before and everyone was talking about, and so I just thought, you know what, being in New Zealand, I kind of like being the little brother, and I'm literally I've got an older brother. I'm literally the little brother. And so I like, you know what, I'm going to support that team. Bad decision.
Yeah.
And I can't give them up. They're quite addictive, aren't they, Marika?
Oh, yeah. Well, we need masochists in the world, so thank you for being a part of that. I'm a St George Illawarra supporter in rugby league, and we are almost eternal masochists as well. So
you've won a premiership, though, surely.
Yeah. 2010, we made lots of grand finals, but yeah.
Slightly small. But Kieran, on your topic of having specialist physios, I mean, it does seem to be happening a little bit not specialist physios, but the one that does triaging.
I don't think it has to be a specialist physio, but although I think that pathways, I think the APA has got a good direction with that, and the college has got a good, now we have titled members are now a part of the college, which I think is great. But I don't know if this is the point you're going to get to, but I really think that experienced and trained physios in an advanced scope or first contact role.
That's the term I was looking for. Yeah, I did. The word specialist came out, but I didn't mean like that specialist. But I was just thinking of people like Piers who works at Fiona Stanley, and I don't know how much of that's over at East as well, Anthony, where there's highly skilled musk physios working in the ED emergency departments, actually triaging all the musculoskeletal stuff. But then once you're outside that very acute setting, there really is no way for them to go apart from private, pretty much.
And the whole, I think we really do have a big role to play, like you were saying, Kieran, in having physios being able to do that. Of course, the cynic in me thinks, okay, well then those physios will become incorporated with the medical establishment because they can afford to pay them bigger money. But I remain optimistic. In terms of helping the people who've survived so far through our particular conversation, this podcast, what I'm hearing is for the public to hang in there if you've got something that people are saying needs an operation. Obviously, if you've got, you've lost the use of your arm or leg, you have unbelievable red flag symptoms, sure. But things like an ACL, a shoulder reconstruction, an ankle reconstruction, I'm hearing, look, let's just wait. There's great evidence for the cutting edge leading approaches of using the different things that physios and other health and fitness professionals can do to help. For those who are at the coalface, health and fitness professionals, hang in there. Let's stop fighting and bickering about the little itty bits and pieces, but rather let's use the combined strength that we have together to advocate for better outcomes for people. And we know around the world that women's healthcare outcomes are just lower in general. So let's band together and seek to help support each other. We don't have to agree to have the same aim of providing the best healthcare outcomes for people, which I think all of us agree. That's what we're trying to do. And for those who are a part of the medical establishment as specialists or general practitioners, please know that nobody's saying that operations are useless. A little bit more judicious choice, maybe utilize more of a team care approach. How's that sound as a summary?
Absolutely. I love that. And in Perth, informally, it's not, maybe in the future, it might be more of a formal thing that I do, but I've got local surgeons who will send me ACL full thickness tear patients. There's been some cases where I'll send them back to the surgeon who send them back to me for my opinion. So I think it can be, you may say I'm a dreamer, but I'm not the only one. I think there can actually be a collegial, peer-to-peer, interprofessional team where you have all moving parts working together. I don't think it's like, I'm also agree with you. I'm optimistic. I think it can shift. It does. There's many barriers, and some it takes leaders within each profession. And I've got a quasi team. I've got a sports doctor that I refer to who refers to me. I've got a surgeon who I refer to, he refers to me. And I think I think patients love getting those multiple. They love it. And then on the whole, to be honest, I agree. And then I think it also within physiotherapy, we have to be honest and go, well, look, this patient needs another view. You've got to have that. Where's our limit? And, the same applies in other professions, but I've seen it work well in all cases. And I think that way we can get a balance.
I think the threat for so many is seeming irrelevant. And this is all professions, by the way, seeming like you're irrelevant or out of touch. The existential crisis that I was talking about before was people going through, what am I even doing here? Am I even doing anything? What am I doing to help people if none of this is true? And the thing is that what we do helps. It just may help for different reasons to what we were taught. And the same goes for doctors and surgeons. I have zero doubt that what they do helps those, that it helps a lot, and they've helped so many people. The reasons why, some of them might be for what they think, and some of them may not be for what they think. And you know what? It's that professional relationship, I think. Being able to sit there and have a non-threatening conversation instead of somebody yelling at you on Twitter or Facebook, getting alongside, having a decent conversation. And that biopsychosocial approach, the thing that I find helps in those conversations, for me at least, is to acknowledge that they're doing the very best they can for people. They truly want to help, acknowledge that they've done so much good already, and then start from that base and let's talk about how we can do even better, as opposed to trying to rubbish people for what they do. Like if any of the providers that are listening out there, I think that's the way forward. Like you said, right at the very start of this podcast, why are we fighting over the little itty bits and pieces? Let's get together,
Yeah. And I think it's, at least with the relationship, there's two that I mentioned before, the sports physician and the surgeon, it's very friendly. It's not like, and I'm genuinely interested in their view and their opinion. And more often than not, we've come to the same agreement. And I think there's sometimes where you have to really think, okay, well, maybe sometimes you have to stand your ground. But most of the time, I think you find you've got more in common. And I hope that physios in the future get more confident as well in backing themselves, because there's sometimes where absolutely the best thing for the patient is what we can offer. And we have to be an advocate for them, because it's not always, it's sometimes just missed.
I'm cognizant of the time, Kieran, because we could probably talk to you for hours. So I'm just going to have one more follow-up question. One of the things I know you're really passionate about is supporting physios in practice in general, and Auntie and I have both very much come from, I think, a place of it sounds really woo-woo, but of abundance. Like there's plenty of work for all of us. Don't feel a very competitive spirit with the people next to me. If I kind of think someone can do a better job, I'm very quick just a handball on and say, oh, this person
Yeah.
is really good at X, Y, and Z. And I get
Yeah.
a ton of referrals from other physios. And
Yes.
I think, you know, I'd love to hear your advice really for physios who starting out, especially if you're, you know, maybe not quite so confident in your skills. You want to upskill your game. You know, what would be your sort of top tips for somebody who's new in private practice in particular? And I would 100% agree with getting mentoring. I think that's absolutely critical.
Yes.
But beyond that, yeah, what would be a couple of quick tips that you would suggest?
Yeah. I think absolutely you should avail yourself to consistent mentoring. The research evidence that I've read is the smaller groups, the better. So ideally one-on-one, because you're much more likely to open up and be frank. And if it's one-to-one, and that's probably my model, and that's probably how I've seen it work best for me. And I think it's okay to get multiple mentors and just be as honest and open as to how you're going and what your feedback is. The changes are quite dramatic in the first year, but I still want to keep improving. So like myself personally, in a year's time, I want to be better than what I am now. And like you said about the abundance mentality, I fully agree with that. I don't even think the fact that Anthony is doing mentoring, I love that. I think it's amazing. We need more leaders of leaders, more mentors of mentees. The more we can have, the better. And I don't think it is competitive at all. There's not enough mentors. So I think, getting other physios to look at your cases, even an individual case, is a great way to learn. It's one of the best ways I think you can pick up clinical tips or questions and strategies you may never have learned. You just didn't know. And it's not like a personal judgment. You just didn't know. And so I think for me, that's probably been in my career the best thing I've done is consistently, and probably in life as well, and all sorts of things. I think, people's relationships and whatever, you have to always get people giving you, finances, whatever it is. You got to get people giving you counter perspectives. And because you can it's quite easy for all of us to get locked in a certain way of thinking. And yeah, I love that thing about the abundance, because I just see in the future, physio has so much potential to impact more than ever. I don't think the profession's ever been better placed, personally. And the APA and what they're doing is amazing. And so I'm in fully support of it, even though I did slowly ditch that group that we were in. But yeah, I think it's such an exciting time to be in healthcare, and what physio can offer is quite powerful. And we need to be offering it more.
Look, thank you very much for all of that. Like I said, not the podcast that I had imagined, but the podcast that I love. We've covered so many different things. What drives healthcare. We've talked about, how our role as physios, and I know not most people probably that are listening to this podcast are not physios, but our role in the healthcare system is peanuts from a financial perspective compared to the massive amount of funding that medical gets. We've talked about the evolution of physio from when you did your undergrad through to your specialization and now, and the role of EBP and perhaps, like what we said, the misguided application, I think is a nice way of saying, just simply because not everybody enjoys really wrestling hard with a concept. There are people totally legitimate to just want to turn up to work, do your thing and go home so you can do other things. There is nothing wrong with that. And then we've also covered how, we looked at ACL and the surgical management, and the benefit of waiting. There are people that do need to go have ACL reconstructions. They don't need to have it yesterday. Give rehab a chance, not rehab, give the sexy cutting edge management a chance to really show its colors. because you get a head start on your recovery and return to sport anyway. You know, low back pain, it doesn't matter what it is, which joint it is. It's you know, it's the meeting the individual where they're at. We talked about professionals, we talked about those social media discussions, so much, and the advice right at the end there, having other people look at things and having other physios look at your cases. It's yeah, it's a brave thing to let people see what you do. It's also a brave thing to ask people to critique what you've done. Like you said, it requires a lot of vulnerability, and being able to have a safe space to do that is really important. And it sounds like that's what you and your company provide. Makes me happy. You know, we need, like you said, we need as many people as we can out there. And it's so great to find another ally in the middle, so that we can suffer together in the middle. How was that? Do we miss anything in that little wrap up there?
Yeah, look, not really. No, I mean, I could probably speak more about a few of these different issues if you want, but no, I think I love talking about these larger scale issues in physiotherapy, and I feel like maybe it's a silent majority that are really in the middle, and they're sort of a bit tired of it, and they actually see the value, you know, in women's health and musk. There are two significant areas where physio has the solution, and I think it's there's more that we agree on than not. So I think, yeah, we just need to be confident and find like-minded people to you know, come along, you know, as you said, come alongside and have just as like a, you know, a bit of a team to keep shifting the narrative.
And I think that's where the value in face-to-face, Kieran, is so important too. Like, I know that we had this period of time through COVID and everything had to go online, and that was great. But there's nothing better than attending a course in person and going to a meeting with your colleagues in person and having conversations face-to-face. They never end up being quite as aggressive as what they can be online. But you can really feel, you know, that support of your colleagues when you actually meet up and practice things together and learn together. And I just think, you know, I agree. I love being a physio. I love our job. It's fantastic, you know, and I think that's one of the reasons why I snuck onto the musk board, is because even though I work in pelvic health, like, I think we have too many silos, and we just need to be working in different areas and getting to know what each other does, and referring in and out, and having this big collaborative approach. I'm making lots of hand actions at the moment, but I think you get my gist. You know, I think we can very much stuck in our little silos. And
oh yeah. And, you know, some of you know, I've had some family members that have seen women's health physios, and it's literally changed their life, like literally changed the direction of their life. And so I think there's such power in that. And, you know, not being afraid to very quickly refer on to that. And I don't see it as competitive at all. It's like, and you know, I don't worry about coming to work. I know I'll be busy, but it's just how can I best help this next person the quickest way, you know?
Yeah. Send bloody sensational, mate. Thank you for that. We'll be happy to have you on the podcast again anytime you'd love to.
Get my wife on. Get my wife. Get her on. That will be very different in parenting health, in women's parenting health. If that fits under your umbrella.
It does, actually.
We have a very large umbrella.
We have a big umbrella. So long as we talk about women's health in some way, then I feel like we're meeting our mandate, you know, meeting our charter.
Yeah.
Thank you very much.
Anyone follow Kieran on his socials. He does post very amusing memes. He also likes to share lots of MRIs of, you know, spontaneously healed ACLs, which people go, oh my God, what's going on here? But yeah, it's very prolific on social media. Do you want to quickly share your socials? And obviously we'll put it in the show notes too.
Oh yeah, it's so on Instagram. Yeah, I love memes. So I can post a scientific article In fact, now I think I've got a new strategy where I pretty much, even if I've got an article, I'll just post a meme that relates to the article. Because if I post the article, I'll get like 10 likes or 50. But if I post a meme, I'll get like 100 likes or like 200 likes. So, and I quite like just sitting there and making the meme, you know.
Yeah, you love the memes, don't you?
I love the memes. Yeah. So yeah, it's on Instagram is at global_specialist_physio. And then on Facebook, it's Global Specialist Physiotherapy. And then on LinkedIn, I'm more professional. I'm yet to post a meme, but one of my life goals is to do a full lecture in memes. So I'll just have the meme and then just talk. Maybe some sort of, I don't know, presentation.
You've said it, now you got to do it. So
I've got to do it.
Just do it.
And I'll be real serious. Be real serious the whole time.
We'll have you back on the podcast right before you do it so that we can help publicize your meme-led lecture. How's that?
It sounds good.
I'll even host you on my education website. How's that?
I'd love it, mate. I'll do it full. I'll be serious. I'll actually do a meme for every point.
Beautiful. I'm good with that. We look forward to seeing it. All right. Thank you very much. I'm going to stop recording, but I'm sure we're going to keep talking. Give me 1 second. I'll stop everything. Thanks for having.
Cool.
Thanks for being on the podcast. We really appreciate it.
Cheers, guys.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.